all again for the second session. I don't know every one of you had attended yesterday's session, but continuing from yesterday's session, we did have some brief introduction about these exams, what is expected. We did do few scenarios in a different range to know the essential Viva techniques. And let us continue from there without wasting much time. I have few like 10 to 12 scenarios, but we can extend. So like yesterday, I would need volunteers again today for participation, and my focus would be primarily on correcting the Viva techniques predominantly rather than the knowledge part itself. And I had kept the difficulty of these scenarios very less, I would say, rather than being tough scenarios, so that everyone can participate. So the whole objective of these sessions is for you to understand what is normally expected and how to score more marks and how to keep yourself comfortable before even you start preparing for these exams. Right. Who wants to go first? Anyone? No one? Okay, good. Okay, Tamir also has raised hand, so I would request others also to raise hands if you. Okay, let me go with Jamil, because I think I did ask a question and Tamir yesterday. Jamil, you want to start? Can you switch on your camera if you don't mind? You're muted, Jamil.
Hi, Mr. Mani.
Yes.
I'm
not in a situation. That's okay.
I'm
but
on call, but yeah, I can just see.
Will you be able to participate in the waiver?
Yes, I have some time, but my mind goes
That's
off here.
okay. That's fine. Just fine. Right. So imagine you are the consultant on call. You're doing a clinic. Okay. And
Yes.
one of your patient is coming to your clinic who had a laparoscopic cholecystectomy for recurrent biliary colic 6 weeks back. Okay.
Yes.
And patient is coming to your clinic today for follow-up. Okay. What all you will do?
So first of all, I will take a focus history, introduce myself, and I will ask about the how he's feeling after the surgery, and I'll ask is if any issues after the surgery, any complications related to surgery that he wants to discuss with me, or is happy with everything, or if he wants to raise any issues.
Mm-hmm. So patient is telling that, yeah, doctor, I am fine, except that my pain has never changed. So
Okay.
whatever pain I had before the operation is exactly the same now.
So I will go through the operation notes of this patient to see how did the surgery go, and then I will check the histology report and also check the indication for the surgery. And then we'll discuss our acknowledge his concerns, and then I will tell the patient that there is around 1/3 of people might not get better after the surgery, and the symptom might still persist, and we might need further investigation for this.
Okay, so you went through the operation notes. Operation notes is a very straightforward, uncomplicated cholecystectomy. And the biopsy results has come back as chronic cholecystitis.
So then I'll ask about the symptom, whether it's the same pain, or is it different from the previous, whether it's related to surgery or surgical incision or post-op collection, or is this exactly the same pain that he had before the surgery?
So patient says that I had exactly the same pain before the operation.
So in this case, I will tell
okay, so patient, before going there, what do you, so when I say that this patient had surgery for recurrent biliary colic, yeah, what is how do you describe a biliary colic?
So a biliary colic, which comes in waves, a crescendo decrescendo pattern, and it stays for a brief period of time.
What is brief means what?
I think it's less than 6 hours. And there is no and the bloods are normal. the white cell count in the CRP and the liver function test.
So when you say crescendo and decrescendo, so but you're telling 6 hours, you mean that the pain will be very high for 6 hours and then settle down for 6 hours, or within that 6 hours it goes on up and down?
Goes up and down and should settle down completely.
Really? Is that how a biliary colic is? When does the pain start? What is a typical description of a biliary colic?
So the biliary colic, usually the pain start with eating food, especially fatty
How long
food.
after eating food?
So it's around 2 hours after the eating food, when the food particles goes into the duodenum, and it sends signals to the and it's release cholecystokinin and ask the gallbladder to contract.
That's fine. So basically, it is not a typical colicky pain. It is a constant pain which stays for 2 to 3 hours, even up to 6 hours. And if it persists over 24 hours, it can go in for cholecystitis. That's fine. So the patient tells you that patient has the same pain. So patient came with this pain. You did the operation because the gallbladder had several small stones. She continues to have same pain now.
So in this case, I have to explore other causes of the pain. Especially, I need to rule out whether any dysfunction in the sphincter of Oddi is causing similar pain, or any history of gastritis, yeah, this.
Okay, so this patient is in front of you now. You have told that. So what are you going to order for this patient?
So I would do blood test to baseline bloods, full blood count, CRP, and liver function test, and then I would start with ultrasound again to look at the biliary tract, and then I will arrange, if that's normal, I will arrange
so you did an ultrasound scan. The blood tests are all normal. In the ultrasound scan, you did a ultrasound, and the report comes as bile duct is 8 millimeters compared to 6 millimeters before the operation. Are you concerned or not?
Yes, I am concerned because it might be post-cholecystectomy dilatation, but the surgery is done very recently, so there might be something that we need further investigation.
Okay, that's fine. Okay, so the ultrasound scan comes as bile duct is 8 millimeter, no intrahepatic biliary radical dilatation, no collection. What next?
I will go with the MRCP to have a look at the CBD, especially where it's entering to the duodenum and pancreatic junction, to make sure there is no lesion in this area which causing any proximal dilatation.
Okay, MRCP is normal.
If the MRCP is normal, as the patient had a gastroscopy before, if not, I will. That will be one of my my option to explore. And
gastroscopy normal.
I will arrange a nucleotide scan, like a HIDA scan, for this patient to see if how it's if it's functionally this duct is okay, and there is no problem with the sphincter.
So what is HIDA scan? What is HIDA scan?
It's a nucleotide scan where we give a nuclear injection to the patient, and then we scan to see whether
what injection is given.
It's not on my top of my head now, but
okay. So what is the principle of this HIDA scan? So you give something. So what is this? What is the principle, or what is the quality or the characteristics of the drug which you give IV in this patient?
It's tell us the secretory function of the biliary tree. Yeah.
And what do we see? So you gave this drug intravenously, yeah. And so how long the images will take? Normally, it is a serial images, isn't it? So
Yes.
they will take an initial image, then every hour they will take until. So what do they normally see? What all the, so when you see a HIDA report, what do you want to see in the HIDA report?
No idea. It's not on.
Okay, so no, that's a good thing. So you try to do a HIDA scan, but what are you expecting? Leave the report. So what are you expecting in this? Why do you want a HIDA scan in this case?
So to see the functions, for it's basically to see if this release from the liver and follow up down to the duodenum to everything is fine. That the
so what are you expecting? What are you expecting in the HIDA scan, which would explain the patient's problem now? What are you expecting? So what is running in your mind at this point? Ultrasound is fine. MRCP is fine. You did an OGD, which is fine.
So two things. One, it might be sphincter of Oda dysfunction.
Okay. So what do you see in sphincter of Oda dysfunction in HIDA?
No idea.
Okay, that's fine. So you did a HIDA scan and it says that the absorption is fine, but there is a delayed excretion of the mebrofenin. Mebrofenin is the drug which we give IV. This mebrofenin into the duodenum suggestive of functional motility disorder or a biliary dyskinesia.
Yes, biliary dyskinesia basically. Yeah. The term I wanted to use.
So biliary dyskinesia, although it is, so what is biliary dyskinesia? So biliary dyskinesia is a type of an, the functional drainage problems of the bile duct. However, biliary dyskinesia we specifically use for gallbladder itself. So when a patient comes with typical biliary colic pain, and you do an ultrasound scan, you don't find any stones. Okay, you do an MRCP, everything fine. You do an EUS, everything is fine. Then you do a HIDA scan to see if the patient has biliary dyskinesia or not. Okay, so what in the HIDA scan you will look for to diagnose it as a biliary dyskinesia? What do you check?
Is the delay secretory time?
No. What about the gallbladder? So what do we check is a gallbladder? Yeah.
The contraction of the gallbladder. That it's.
In other words, ejection fraction. Yeah.
Ejection fraction.
So the ejection fraction of the gallbladder is what we see in biliary dyskinesia. If the ejection fraction is below a significant level, if it is less than 35 or 40, if I'm not wrong, okay, we consider it as a biliary dyskinesia, and the treatment would be to do a cholecystectomy. But in this case, so any patient, okay, where patient presenting typical of the biliary colic, and you say, for example, this patient comes and you did a HIDA scan, and the HIDA scan shows an normal ejection fraction, and you're suspecting sphincter of Oda dysfunction. So what is the diagnostic test to confirm whether it's a sphincter of Oda dysfunction or not? Manometry. ERCP and the sphincter of OD manometry. However, no one does that nowadays. Okay, so whenever, because if you speak to the gastroenterologist, they say that it is never a confirmatory test. So whenever they suspect, they just do an ERCP. Okay, the treatment of sphincter of OD dysfunction is what?
Dilatation of
exactly. So it's like a sphincteroplasty or a sphincterotomy. Okay, they just do a sphincterotomy. So that's what they do. Okay, right. So this is a very typical and a simple case of post-cholecystectomy pain. And this, as I told, this scenario can lead to several diagnoses. One, it could be sphincter of Oda dysfunction. It could be a post-op surgical complication itself. It could be a small bilioma. It could be a retained foreign body. It could be a retained CBD stone, or it could be a completely different pathology where you deal with acute gastritis, you deal with pancreatitis, you deal with, say, inflammatory bowel disease, several things. Okay, so again, what I would have expected is when a patient tells a patient has a similar pain, you need to tell You need to express your higher order thinking. You need to tell, I am concerned about this patient. The possible differential diagnosis running in my mind, or it could be a biliary problem and it could be a non-biliary problem. The biliary problem could be 1, 2, 3, 4, 5. The non-biliary problem could be this. First of all, my priority is to see whether the patient has recovered from the surgery or not. I would see whether patient's pain is okay, whether patient is eating fine, opening her bowels are okay. I will do an abdominal examination, port sites are fine. I will review the biopsy, which is very good. Okay, if you had not told that, I would have taken the scenario into a different way. Finally, I would have told the gallbladder biopsy has come as low-grade dysplasia, what you will do. Okay, so you have done that. Then you need to go step by step again. So you did an ultrasound scan. However, you won't be penalized if you straight away say, I want to do a CT scan. Yeah, because no one does us an ultrasound scan nowadays unless it's a pediatric age group. So the first global investigation you would like to investigate following any surgery would be a CT scan with contrast. And normally what they would ask is, what do you want to look for in the CT scan? Okay, you need to tell very clearly, I want to first of all see if there is any surgery related problems, which includes collection, any foreign bodies. Then I want to see about the bile duct, whether it's a dilated bile duct, again, whether it's intrahepatic or extrahepatic bile duct. Okay, and then you go look for other pathologies, if there is any features of pancreatitis, bowel thickening, colitis, etc., etc. Then, of course, you will go ahead and ask for an OGD if not already done. Okay, then you need to know, so the most common cause of post-op pain would be retained CBD stone rather than a sphincter of Oddi dysfunction. Sphincter of Oddi dysfunction is much, much rarer. So you would go ahead with an MRCP. If MRCP is normal, I would still go ahead with an EUS. Okay, I will again go with an EUS to see if there is any stone or not. And then probably I would go with the HIDA scan. So the HIDA scan is a special nuclear medicine scan, which helps in identifying not only the secretory functions, it helps in identifying what is the absorptive function of the liver and the excretory function of the liver. And the characteristic feature of the drug which we use here is it is completely absorbed from the blood, and it is completely excreted by the liver, and it is not reabsorbed by the liver. Okay, not reabsorbed into the circulation. That is a characteristic. That's how you see. So the moment you give, you will see an initial image. The second image, you will see the uptake in the liver. The third image, you will see in the bile duct. In the fourth image, you will see in the gallbladder. Fifth image, it goes to the duodenum. And you will, over a period of 6 hours, they will take images until the entire biliary system and the liver is cleared up. Okay, so this is what you see. So again, as I told it, we went from a simple question to a complex question. So can I ask you, in your clinical practice, what are all your indications for performing a HIDA scan?
I'm basically a colorectal surgeon, so I haven't done much.
Do you do cholecystectomy or not?
Yeah, I am doing cholecystectomy,
okay.
But I'm very rarely, if I've never seen anyone who had a
fine,
CT.
but you can tell. What do you think would be the indications for HIDA scan? Of course, we discussed 2 indications now. One is for motility problems, biliary dyskinesia you do. What other conditions we use HIDA scan?
We can use HIDA scan for cholecystitis also if it's not diagnosed on ultrasound.
Yeah, that was a traditional, maybe historical test, and that too we don't do a HIDA scan. We were doing something called oral cholecystogram. Okay, so what do you see in acute cholecystitis, if at all, if you have done a HIDA scan? You did a HIDA scan in acute cholecystitis. What do you see? Or in other words, how do you diagnose acute cholecystitis with HIDA scan?
Not sure about that, but on ultrasound we do thickening of the gallbladder.
So in HIDA scan, the gallbladder will not be seen. You know, the primary pathology of acute cholecystitis is occlusion of the cystic duct, isn't it? So the cystic duct gets occluded by a stone or whatsoever, and then develops acute cholecystitis. So when you do a HIDA scan, the gallbladder will not be seen. That is how you diagnose acute cholecystitis with the HIDA scan. Okay. So normally, so can anyone else say what are the other indications for HIDA scan? Is there any HPB trainees here? No. Qasim, tell me, Qasim.
Yeah, I'm not The other indications are to rule out any stones in the cystic duct or in the CBD.
Oh, HIDA scan. You know, have you seen an HIDA scan image? No. So HIDA scan is just a shadow. It is very, very difficult to see if there is a stone is there or not, and things like that. Yeah, it just says a shadow. You know, so HIDA scan is a kind of what scan is it? So you told it's a nuclear medicine scan or something. So what specific type of nuclear medicine scan it is? What is it? So you all know PET scan is a kind of a nuclear medicine scan, isn't it? So what is HIDA? It is called SPECT. It's called single photon emission computer tomography. It's a SPECT scan. Yeah. So what else? What other situations you can use HIDA scan? So normally, again, it might be difficult for you. So we do HIDA scans in situations where a post-op patient is having a bile leak, but we are unable to find what is the source. Yeah. For example, you did a cholecystectomy and the patient has bile in the drain. You do an ERCP. ERCP is not showing any bile leak. Yeah. So let me continue with the same scenario. So who wants to take this up next? Qasim, you want to take it up?
Yeah, sure.
Right, Qasim. So imagine you have. Were you happy to switch on your camera so I can see you? If not, it's okay. That's fine. So imagine you did a cholecystectomy. Okay, a straightforward laparoscopic cholecystectomy. And next day you're going and it had some bleeding and stuff. So you have sorted it out. You had kept a drain. Next day you're going and seeing the patient. Patient is clinically fine, but you see bile in the drain. How do you manage?
So first of all, I will, is it my patient? I have operated at someone else's patient that I'm looking after, sorry.
So it's your patient.
Right. Okay. So I'm aware of the operative situation when I did it. It was a straightforward operation. And the things that are going in my mind is, as I can very well recall, the operation went very smoothly and I wasn't very concerned at that time. So the things going on in my mind is that it could be some bleed from the gallbladder fossa area or a duct of Luschka that I have missed during the operation, and it has just shown up now. The good thing is that I put a drain in and it's appearing there. So my aim at this stage will be, as a primary surgeon, to observe closely because based on my personal experience of cholecystectomies, if it is a mild leakage from the gallbladder fossa area, usually it settles down because the bile takes the normal and less resistant route to the ducts. If it is patent and there is no blockage, it usually settles.
So you saw this patient, and so day one bile leak, you see 250 ml of bile in the bag, but patient is clinically fine. Abdomen is soft, non-tender. Would you do any investigation at all, or you don't do anything?
Yeah, as I said, I mean, I'm aware of the situation, and one thing, as I mentioned earlier, what could be a possibility? The other possibility is, despite of very
no, my question is very clear.
Yes, sir.
Will you do any investigation or not?
Yes, I will do.
Tell me what investigation you want to do and why.
I will do a CT scan first to see if there is any significant collection in the gallbladder fossa area, or if I can highlight any other major collection or other injury in that area.
Okay. So when you ask for a CT scan, yeah, what CT scan you want to ask? You want a CT with contrast, plain CT scan, or triple phase, single phase? Why?
Yeah, it will be a CT scan with IV contrast.
Triple phase, venous phase. If you just ask for a CT scan with IV contrast, what imaging will the radiographers will take, or the radiologist will ask for?
Yeah, usually with the IV contrast, it's a venous phase that they provide us.
Exactly. So, are you happy with just a venous phase in this case, or do you want an arterial phase for some reason?
I will ask for an arterial phase in this situation.
Why do you want an arterial phase in the situation?
Because that's a bit delayed phase, and it will highlight more of the arterial channels and anatomy in that area.
So arterial phase, is it a delayed phase or an early phase? What is the first phase when you do a contrast CT?
So the first is a non-contrast, and then it comes the early arterial phase, then delayed arterial phase. I mean, venous phase is the first one actually that comes immediately. Then early arterial, late arterial, portovenous, and then excretory phase.
No. So it comes with artery first. Okay. So it's a non-contrast. Then you have an arterial phase. Yes, as you rightly mentioned, there is something called early arterial. There is delayed arterial, and then you have a portovenous phase. The venous phase, portal phase is the same, and then a delayed phase. Okay. So why do you want an arterial phase in this patient? Why?
I also want to rule out because it's common that when there is a biliary injury, there is also chances of an arterial injury as well. So my main aim at this moment is to rule out any arterial injury as well.
Exactly. So you did a CT scan with an arterial phase to look for an arterial injury, look for collections. What other investigation you want at this point?
Then I will go for an MRCP. My main aim is to rule out any bile duct injury.
You want to do on this patient is clinically fine. You want to do on the same day, or you want to wait and see if it settles or not?
I mean, it's on the first day, it has drained around 300 mils of bile in the drain. That's to me, it's concerning. And instead of waiting, it's better that I can have some investigation to pick the injury early rather than just waiting.
Imagine if it is like a 80 ml bile. Will you not do an MRCP?
I wasn't expecting any bile actually because it was a quite straightforward operation. So I don't think it's because a non-invasive investigation. I think it will still give us satisfaction and peace of mind. If there is a bile, I'm concerned, I will go ahead for it.
Okay. So to everyone, in the UK, any patient with a bile leak post-op, okay, the safe answer in the exam is you do an urgent CT angio and an MRCP urgent. Whether, of course, if the patient is peritonitic and stuff, it's a different story. Even if the patient is stable, always do a CT triple phase angiogram and an MRCP. The reason being, the main reason for the bile duct injuries is visual misperception. Yes, you believe very firmly that you didn't do any mistake, but it could have still happened somewhere which you had missed. Okay, that's a common way of presentation. So you need to do an MRCP and a CT angiogram on day one, because if you had picked up any injury on day one, that is the ideal time for the patient to go to any referral center, and the correction surgery is an option. Okay, so always tell that, irrespective, even if it's a mild leak and stuff, you won't be penalized for doing this, rather than waiting for 3 or 4 days and then you do it and have a problem, and by the time you lose the safe window of going and doing a repair. Yeah, fine. So you did an MRCP and the MRCP is fine. Everything is fine. MRCP is not showing, that shows an intact bile duct, a good cystic duct stump. Everything is fine. And CT abdomen, CT angiogram, no arterial injury. The drain is in place.
Yeah, that's reassuring for me.
Is it reassuring or you're worried?
Yeah,
300 ml bile. 300 ml bile, but the bile duct is fine.
Yeah, no, I was taking the 80 mil you said. So coming back to 300.
Yeah, let us back to 300.
Yeah, so on one side, I'm reassured that I have not injured any major duct, but on the other side, the other sources that could have caused it, it could be a ducta flusca that is causing this continuous bile leakage.
What else could be the reason? If it is ducta flusca, are you happy or sad?
I mean, usually it slows down and it ease off as the time passes. Usually, if the main duct is patent.
Okay. What else? What other injury you would expect?
Or it could be an accessory duct that I have not visualized. It could be an anatomical anomaly that I have completely missed.
It could be a posterior sectoral duct. Although I told that MRCP is normal, but if I had just told that MRCP is showing intact bile duct with a cystic duct stump without me commenting anything about the intrahepatic duct, you are expected to ask whether the intrahepatic ducts are fine, whether the right anterior, right posterior, and the left ducts are joining. Because if you see even the classification of the bile duct injuries, one of the type 2 and type 3 injuries are involving the posterior sectoral duct. The posterior sectoral duct, either it is clipped or divided, okay, and leaking. Okay, so that one we need to see in the MRCP. So the reason why you do an MRCP, yes, you need to look for the bile duct injury, look for a cystic duct leak, and also look for the intactness of the 3 ducts, especially the right posterior sectoral duct, which is at a high risk of getting damaged. Okay, fine. So in this patient, you imagine that they could see the anterior posterior, but the right posterior sectoral duct is leaking. What are you going to do now?
I mean, the options I have is if one is requesting an ERCP and stenting. The other option is I rebook, do a laparoscopic washout, and if the stump is visible, I just clip it.
So you are going to close the right posterior sectoral duct. So right posterior sectoral duct drains the right posterior sector of the liver, isn't it? So it's not like a duct of Lushka or something where you can just clamp or put a stitch. Yeah. And do you think that ERCP would help here?
Yeah, I take my previous answer back, if you allow me, and I reassess this situation. And in this situation, because patient has a drain already, he is not peritonitic, I think this is the time that I have to talk to the hepatobiliary surgeon, because this is a time and situation which is beyond my expertise now. And I will talk to a hepatobiliary colleague, explain the situation, discuss and share the MRCP images, and request their expert opinion with the view of taking over the care for a reconstruction, basically.
Absolutely. So as a non-HPB surgeon, okay, the only bile leak, post-cholecystectomy bile leak, which you can manage in your unit would be a cystic duct stump leak, okay, or a gallbladder bed leak with an intact posterior sectoral duct. Okay, except for these 2 leaks and patient being asymptomatic, you can manage. The rest all needs to be referred to the HPB team ASAP. And even to be safer in the exam, even though your MRCP and CT is showing, you would still say that you will discuss with an upper GI or a HPB colleague to make sure everything is fine and what else I need to do. This patient needs to be on antibiotics. Patient should stay in the hospital. Make sure you put some 2 or 3 more stitches in the drain so the drain doesn't slip out. Yeah, all these things needs to be told. Okay, so I'm not going to go in depth into it. Still a lot more to discuss, but I am not going to discuss because that needs a lot of things. So one of the indications where we use HIDA scan is in situations like this, where you have done some surgery and there is a bile leak, okay, and you did an MRCP, you did a CT scan, you cannot find the source of the bile leak. Okay, so in those situations, we can do an HIDA scan to look for where exactly is the leak. Okay, for example, Qasim, I'm telling you, you did an MRCP. The MRCP is showing perfectly normal MRCP. Everything is fine. Right posterior ductal duct is fine. Everything is fine. Where else it could be? There could be a leak in this patient. See, a drain is showing 300 ml bile. You did a CT scan, no collection. MRCP showing intact bile duct. Right posterior, everything is fine.
So it could be a liver parenchymal injury from where it could be a leak.
CT scan is showing a very normal liver, and you are very confident that you didn't injure any liver. What else it could be?
Duodenal injury?
Exactly. It could be a duodenal injury. So everyone forgets this. Okay. Excellent that you thought about that. Everyone just stops there. Okay. And they will not go into this duodenal injury at all. So it could be a duodenal injury also. So how do you know it's a duodenal injury? How can you confirm that?
A CT should show actually some
CT may not show.
fats.
Yeah, means because post-cholecystectomy, everything will be inflamed, and day 1 you may not be able to see anything, isn't it? Is there anything which you can do which can give you a clue that it could be a duodenal injury? No? Anything you can do with the drain fluid?
With the drain fluid, yes, I can set it for examination and checking MLAs and the what's called cytology of the fluid.
It's not cytology, biochemistry, yeah.
Sorry,
so you
biochemistry.
send a drain fluid for bilirubin. Drain means, of course, it's bile. You also send for a drain fluid for amylase. If the amylase value is high, obviously it is some enteric leak which is causing the bile leak, and you manage. Okay, so this is another indication for a HIDA scan would be in settings like, again, it is for HPB trainees, not for you. So in situations, say, where you did a say, for example, in a transplant setting, to see whether the liver graft itself is functioning or not. Okay, because the HIDA scan not only tells about the bile duct, it also tells how the liver absorbs and excretes bile. So in order to assess the functioning of the liver, we do a HIDA scan. And in a pediatric age group, okay, if you have a neonatal jaundice, not setting, and if it is far away from the physiological jaundice time, you do a HIDA scan to rule out biliary atresia. Okay, so these are all the common indications for HIDA scan. Okay, good. Any questions so far, guys? So you can see how, so again, in the exam, every question comes from whatever answer you say. Okay, so it is in your hands to keep yourself, relaxed in the exam scenario, rather than putting yourself into trouble. So if you see the question booklets or whatever provided for the examiners, they are provided just the themes. They are not given a particular questions on what you need to ask. So it all leads from whatever you say. For example, you say you told at some point that you will do a laparoscopic washout and stuff. Okay, if you have not taken back this question, I would have just gone through into the surgical man. I would have told, oh, you did a laparoscopic washout, you see, and there's a lot of bile there, and you had injured the liver. Now what are you going to do now? I can go there. So you should develop the habit of controlling the examiner by you, rather than examiner taking you with them. Yeah, so you should be very, very careful on whatever answer you say. And it is always appropriate to tell in the exam that, sorry, my previous response is wrong, I want to take back. Okay, so that is some quality which you all need to develop, because I have seen several situations where candidates would tell a wrong answer and they will try to substantiate that in order to and go into a defensive mechanism. The examiners here are all very, very experienced. They know whether you are bluffing or not. Okay, so it is always okay to tell, sorry, I want to go back. Okay, that's acceptable. Good. Right. Who wants to go for the next scenario? Okay, Chris. Okay, Chris. So imagine the same situation. Okay, so you did a laparoscopic cholecystectomy. Patient comes back after 6 weeks. Okay, and in 6 weeks' time, you are reviewing the biopsy reports, and the biopsy report comes as chronic cholecystitis with focal low-grade dysplasia. That's the biopsy results.
Okay.
So what are you going to do now?
I mean, I've seen this patient in clinic, presumably.
Yes.
So I'd go through, as Kasim did, exploring the patient's symptoms, checking they've recovered well from the surgery. I don't know specifically what, if anything, I need to do about that information. I mean, it's not a gallbladder cancer, but dysplasia. My gut feeling is that if it's been completely excised, that may be all the management that's necessary. But I would, in that scenario, I would probably check with an HPB colleague about whether this patient requires any surveillance. But my instinct is that they probably don't. I think
so what can you do? So you are sitting in the clinic now. This patient has come. You're seeing the report. Okay. First of all, within the report, what do you want to see? So of course, low dysplasia is dysplasia.
Yeah, so
it's not normal, isn't it?
Have they graded it? Have they said low grade, high grade?
Yeah.
Have they commented on whether it's up to the edge of the specimen? Was it fully excised within a small portion of the wall, for instance? So those would all be reassuring factors.
What else? So which location in the gallbladder, if there's a low grade dysplasia, you'll be happy?
In the fundus.
Okay, fundus. Okay,
on
what else?
on the peritonealized side, not on the liver
Okay,
side.
on the anterior wall, if there is, it is okay. Okay, if it is posterior wall, you are worried. What else you want to look for? Where do you don't want a low-grade dysplasia apart from the posterior wall?
I guess at the distal margin, so on the CBD, CD junction.
Cystic duct.
Yeah.
Yes, exactly. So you need to, whenever there is an abnormal biopsy results, whether it's a cancer or it's a high-grade dysplasia or a low-grade dysplasia, you need to see where exactly is this location. Okay. What is the cystic duct margin? What is the posterior wall? Whether it is completely excised or not. So this tells us a lot more information on the further management. So what next? So in this case, for example, you see a low-grade dysplasia at the cystic duct stump.
Okay. So as I said, I probably would discuss that with an HPB colleague about whether this patient needs either surveillance or potentially reoperation, a more radical repeat surgery and a more radical excision. I've probably got all the information from the patient in terms of the patient's been through a clinic pre-op. So
in the exam, yes, you need to appreciate. So two, three things you need to tell. So once you see the biopsy results, whatever I had told, you need to mention that these are the things I will see. The second step is you need to explain the patient that this has happened, which is not normal, and you need to tell that you are not the specialist. Third thing is you don't need to call a HPB colleague. You have MDTs for all the specialty. Just put forward in the MDT. If in doubt, put it in the MDT. Don't call anyone in the middle of the clinic. You tell that I'm going to put forward in the MDT. They will discuss in the next clinic. I will come and tell you. Okay. What would be the management? You don't need to know. Okay, so because this goes into a specialist level, but again, for a low-grade dysplasia, we really don't have a clear idea on where you want to go. Okay, so if at all, if it's an anterior wall, we don't need to bother. We can even discharge the patient. If it is posterior wall and fully excised, again, we can discharge the patient. If it is posterior wall and if it is on the margin or in the cystic duct stump, we have to explain the patient that there is some risk, and I would be on a safer side. I will do a surveillance. So again, even sitting in the MDT, we discuss this and that. When it comes to a high-grade dysplasia or a T1 gallbladder cancer, that's when everything turns, because we need to make sure that everything is clear, and sometimes patient needs to come back for a gallbladder fossa resection and things like that. Okay, so this is about a biopsy, again, a very, very common scenario in your exam. Biopsy turning out to be cancer, biopsy turning out to be low grade, biopsy turning out to be high grade dysplasia. Okay, Chris, imagine you are doing a cholecystectomy, okay, and you are trying to, it is a chronic cholecystitis. The gallbladder wall is so thick, okay. You are trying to achieve a critical view, but you could not achieve a critical view because it's all frozen. What will you do?
So there's a number of different things I could do. I could consider doing a fundus first approach. If the gallbladder is tense, I could aspirate it. At all times, as a non-HPB surgeon, I'm considering whether or not I should be bailing out. If it's very hostile or I'm overly concerned about the risk of injury to CBD or other structures. So I think, I'd aspirate the gallbladder if it was tense and I was struggling to mobilize it from that respect. Could think about extra ports in terms of extra retraction to improve my views.
Yeah, so only one thing you have told so far, although you were talking for 1 minute. So fundus first approach, you will do what else?
It depends what what's the difficulty that I'm having. Is it access or
no? So you see that the Calott's triangle or the hepatocystic triangle is frozen. So you are trying to do a fundus first approach. Okay, that's fine. That's the only option you can do. Okay. So apart from fundus first approach, what other safe thing you can do? So what is the problem with fundus first approach? The problem is you cannot retract. Once the fundus comes out fully, it is quite very difficult to retract here and there, and it will be dangling. So the best thing would be go to the body of the gallbladder, try to create a posterior, keep the attachment of the fundus there, and go to the body of the gallbladder, create a posterior window, and then come down. Okay, so whatever, but you can still do a fundus first approach and things like that. Okay, so you're trying to do that. As you come down close to the hepatocystic triangle, you see bile tinged fluid there. You see that when you're trying to dissect it from top down, you see bile coming out from somewhere. What are you going to do now?
My first thoughts are to try and establish the anatomy. Is this like a posterior, Luschka type duct injury, or have I got very medial and am I on the CBD, or
so how are you going to do that?
If I've got the cystic ducts skeletalized, I could do a on-table cholangiogram. I call for a radiologist and set up for an on-table cholangiogram. If I've got,
how will you do an on-table cholangiogram?
Well, it depends if the cystic duct dissected out. But
imagine you have got the cystic duct dissected.
Yeah. So I'd place a clip on the gallbladder side. I'd open the cystic duct partially, and then through one of my my laparoscopic ports over the fundus, I'd deliver
what catheter you will pass in?
I don't have that, no.
What contrast will you use and what dilution?
No, I've not got that.
Exactly. So if you're a non-HPB trainee, yes, you can tell intraoperative cholangiogram as long as you have done by yourself, or else just tell that I am worried. So what else you will do? So what if this bile leak could just be from the cystic duct itself, or you would have made a posterior perforation in the gallbladder? Yeah, it could be. So you try to identify where exactly is the leak. Okay. Obviously, you need to separate the gallbladder fully to make sure if the leak is from the gallbladder itself where you have perforated. If not, it is something coming from one of the hilar structures or in the common hepatic duct or even in the common bile duct. Okay, so what are you going to do now? One option is intraoperative cholangiogram if you had the expertise. You don't have the expertise now. So what are you going to do?
So my options, and I've got the gallbladder mobilized.
Gallbladder is down now fully.
Fine. So I could complete the cholecystectomy, leave a drain, and then see if a biliary leak develops, and manage it from there. If I've got
how long will you look for? So do you think
the first day or two, I'd expect it to be obvious that there's bile or not.
So do you expect that bile leak to stop by itself?
If it's just a bit of bile from the posterior wall of the gallbladder or a tiny ductal Luschka, then yes. But if it's a more major duct, then no. If I'm in a hospital with other colleagues, hepatobiliary colleagues, I could ask for help during. Is an option.
Yeah, so exactly. So
I think those are the two.
The step would be you need to call your colleague, call for help. If you don't have the expertise, there might be someone else who would be happy to do an intraoperative cholangiogram. Okay, if you have not done enough and if you're not confident enough in doing an intraoperative cholangiogram, don't do an intraoperative cholangiogram. Okay, it is always better to call some other consultant to have a look. Because it is again the bile leaks and bile duct injuries are all visual misperception. He might come and give you a good idea on what you need to do. If not, don't do anything. Put a big drain, call the HPB team, refer the patient on the same day. No waiting and seeing whether this bile leak will stop or not. The HPB surgeon might tell you, normally whenever we get a call from the peripheral centers, we tell that how's the patient. We generally, because we won't have the capacity to accept, but what we generally tend to do is, okay, you keep the drain, do an MRCP, do a CT angiogram and send to us. This is what will be our normal reply. So you do it, start the patient on antibiotics. Again, make sure that put 2 big wide bore tubes because these tubes are the life-saving things for the patient. Yeah. So put a wide bore tube and then do an MRCP, do a CT angiogram, send it to us. we will have a look and we will dictate how it needs to be managed. If it is a bile leak, if you can see a bile leak in continuity with the bile duct, we will tell do an ERCP locally. If it is something else, we will see, depending upon whatever is it, you need to go. Okay, so don't do, it's again a very, very simple question in the exam. During your operation, bile leak, what happens? During your operation, bleeding, what happens? Post-op surgery, patient presenting with bile leak, what will you do? 3 days post-surgery, patient is having bile leak, what you will do? Follow-up, patient comes with a deranged liver function test or jaundice, what you will do? Okay. As a non-specialist, you need to do the investigations, make a diagnosis, and refer. That's all. Yeah?
Yeah.
Good. Any questions so far, guys? Qasim, you have raised your hand. You have any questions, Qasim? Yes, Tamir, tell me. Yes, Qasim.
Sorry, that was previous, sorry.
Okay. Tamir?
Yeah, just a question regarding this dysplasia post-cholecystectomy. You mentioned that we have to do completion radical resection.
That's no, that is only for high-grade dysplasia and gallbladder cancers. Yeah.
Okay. So what about the low?
Low-grade dysplasia, generally, we just follow up if it is in the margins, okay, or if it is in the anterior wall, and if it is completely excised, we discharge them. There is
no
definitely
dysplasia in the cystic duct.
Yeah, if there is no dysplasia in the cystic duct and if it is not involving the posterior wall, we generally discharge. If it is on the posterior wall of the gallbladder and say if it is not resected, say the posterior surface of the gallbladder has a dysplasia or a cystic duct margin has a low-grade dysplasia, again, we explain the patient and we tell that we will do a surveillance and see. Again, there is no definitive guidelines on anything. There are, because generally the chance of these things converting to a cancer is very, very less. We generally, either you discharge or you explain the patient and do a surveillance. There is no specific guidelines for low-grade dysplasias.
Yeah. And what surveillance?
Sorry?
What kind of surveillance?
Sir, we just do a CT scan actually. CT or even an MRI.
Annual.
Yeah.
Okay, thank you.
Yeah, good. Right, who wants to go next? Samir, you want to go next?
Yeah, I can go, but I don't know. There is echo in my
my
mic.
There's slight echo, but that's fine. Okay, right. Okay. So let me see what questions I have for you. Right. So Tamir, you are the consultant on call, yeah, and you have an 82 years old male patient brought to the A&E by the patient's relatives. Patient has learning disability since childhood and has a 24-hour carer. Okay, presenting with abdominal distension and vomiting. Okay, you did a CT scan for the patient and it is showing there is a small bowel obstruction in the terminal ileal region. How do you manage this patient?
So again, I will approach this patient based on the CRISPR protocol. What in my mind is that the patient have cardinal sign of large bowel obstruction, distension, and also small bowel because of the vomiting. So I need to take a history either from the patient if he can communicate or a collateral history regarding the analysis of the complaint, the pain, onset, character, intensity.
Fine. The patient's daughters are there with the patient and the daughters are telling that he used to be fine. The carer used to feed him. He never communicates anything. But for the last 2 days, he has been vomiting bile.
Vomiting.
Yeah. And has not opened his bowels.
And he hasn't. So I'm concerned about the patient that he has a bowel obstruction. So I will make sure that I completed the history by talking about the past medical history, drug history, travel history, any previous previous surgery, sorry, and medical comorbidities, the fitness status of the patient, and the performance status.
Fine. So the patient is 87 years old, as I told. Yeah. Patient is diabetic under control, hypertensive, but has a 24 hours carer at home because of his learning disability. But patient
So
can walk.
he is frail then.
He is not frail, but he needs a carer because of his learning disability.
Right. So I will complete by doing some blood investigation, including the lactate, amylase, group and safe coagulation profile, use and ease, and full blood count, liver function also. I will make sure that someone has put a NG tube for the patient if he's vomiting, and there is a chart, input and output catheter in place, whiteboard cannula, and he's receiving the
So when you're trying to
measures
put in
of
the
IV.
NG tube, so this patient, you did a CT scan, and the CT scan is showing grossly distended stomach, okay, and the dilated duodenum, dilated proximal bowel with the transition and the terminal ileum. Yeah, but
He has no previous surgery.
no previous surgery. But when you're
And
trying
I
to
check
put
the
the
hernia
NG,
orifices.
hernial orifice are fine. Okay, you're trying to put an NG tube, but the patient is not cooperating because patient is learning. He's not trying to swallow. He's not understanding what you're trying to tell.
That's fine. Have I done the digital rectal examination?
Rectal examination you have done, and the rectum is empty.
And the CT scan showing gross dilatation?
Yes.
Including the small bowel?
Yes.
Yeah. So my differential will be a Oglivi syndrome, a kind of pseudo obstruction kind of thing.
Why pseudo obstruction? Why are you thinking about pseudo obstruction now?
The dilated large bowel.
No, no. I told dilated stomach, proximal small bowel with a transition zone at the terminal ileum.
Sorry. And transition in the terminal ileum. Dilated large bowel.
Dilated small bowel.
It's a small bowel, yeah. Is it gastroparesis maybe?
Why are you so much into rare complication? Why can't it be a small bowel obstruction itself? I'm telling you, stomach is dilated.
Virgin abdomen. In a virgin abdomen.
So in a virgin abdomen, what are the common causes for small bowel obstruction?
So volvulus interception, gallstone ileus.
These are all the rarest. What are the commonest?
The commonest is adhesive small bowel obstruction, but the patient has no.
Yeah, that is adhesive post-op. I'm telling in a virgin abdomen, small bowel obstruction. What is the commonest cause? A band, isn't it? It could be a band, just a band.
Yeah.
Exactly. So that's the most common thing which we see when we do a small bowel obstruction in a virgin abdomen. Okay. So this patient, as I told, patient was doing fine. This patient for 48 hours, vomiting, abdominal distension, CT scan showing, and transition at the terminal ileum. Okay. Patient has been vomiting bile. He's not understanding what you're trying to tell. Okay. You're trying to put in the NG tube, which he's not swallowing. How are you going to manage now? What is your plan?
Obviously, a patient has a need a laparotomy because he will not be relieved without a surgical release of this congenital band. So I need to talk with the next of kin regarding intervention.
So what are you going to tell the next of kin? You're going to tell the patient needs surgery, isn't it?
Yeah. I think I need to talk with the radiologist first about the
Yeah, radiologist is telling that it's a small bowel obstruction.
Yeah. And the patient is not settling and we cannot put the NG tube. Well, it's tricky without having a definitive diagnosis. But if he is not improving, he needs the laparotomy.
So what all things you considered before you decided to take this patient for surgery?
Continuous vomiting, and continuous abdominal pain was not relieved with the NG tube, high lactate level, kind of compromised small bowel.
No, that is fine. So this patient, as I told, 87 years old, carer, learning disability. How are you going to consult? Who is going to consult this patient?
Me or the Raj?
No, you are going to consent, but who's going to provide consent? So this patient, do you think the patient can give consent for you?
It depends on the level of the learning difficulty. Some patient with
Yeah, so
learning
patient is
difficulty
not even understanding what you're trying to tell. So obviously he cannot consent, especially with the
So-
learning disability, with such a problem, he cannot. Yeah. So
Yeah.
with the family, you are going and telling that you're, so can the family consent for the patient?
If someone have the power of attorney,
No one has power of attorney.
no advanced directive
Nothing.
decision. So if it is an emergency intervention, I need a second opinion from a consultant.
Mhm.
Uh,
Why do you want a second opinion from the consultant, whether to operate or not, or what is your problem? What is your concern?
no, for confirming for the best interest of the patient to intervene to confirm my decision.
No, but your decision is absolutely right, isn't it? You are a surgical consultant, intestinal obstruction, which is not settling, CT proven, surgery is the treatment. There is no doubt about your management. Okay. But why do you want another consultant opinion in this case? So what? So I am telling you, I am coming in, walking in straight away. Hey, Tamir, why do you want to operate this patient? Just see, he's 87 years old. He is has learning disability. You have 24 hours carer. Just leave him, give best supportive care. What are you going to tell me? This is my suggestion. Don't operate.
Why?
No, I'm telling 87 years old. Yeah, he's has learning disability. He's already housebound. He has a 24 hours carer. Okay, just allow him to die peacefully. Why do you want to operate? So will you operate any patient irrespective of whatever they are? For example, 90, 100 years patient is coming. So what all things you will take into consideration before offering any surgery?
Well, the patient decision himself,
Absolutely, very good. Yeah,
the frailty of the patient, the physiology,
frailty, very, very
the
important. Exactly.
comorbidities.
Comorbidities, yeah.
Yeah, this is most.
Mm-hmm. So how do you know whether the patient is frail or not?
There is the Edmondson frailty
Edmonton
scoring
score
system.
is there. Edmonton score. What is the Rockwood score is there? You can do frailty scoring. What else you can? So how do you assess this patient for surgery? So before you offer the surgery to the patient, you need to know as a consultant. So what is the aim of doing this operation? So this is an 87 years
Relieve the
old. He is not
obstruction.
a fit and well patient. What is your aim of the surgery? Relieve the obstruction. Yes. What else?
Otherwise, the risk of mortality is high.
Mortality, but what is the aim? So is this your aim? So obviously you will tell the next of kin, if you are explaining this operation, that if I am not operating, he's going to die. That's what you're going to tell, isn't it? Yeah. Is that your aim? See, many times, you do all the scoring system, say you do a NELA scoring system, mortality comes as 9% or 10%. Okay. Which means 10% he will be dying, but 90% he will survive. Okay. But if you go and speak to anesthetists and intensivists, they'll tell, no, we should not operate. Okay. They'll tell, no, this is not the appropriate thing. The mortality is high. Why do we say that? Why are we worried that even if the mortality is 10 to 12%, we know that there is a chance that 88% is going to survive, only 12% is going to die, but still we defer surgery. Why? So what is the aim in this operation? So most of us, we understand, when these are all very difficult situations which we face every day in and day out. Okay. Most of us think, especially the surgeon's mentality, especially when we are young consultants, our aim is, yes, we are all pro surgery. That is one. Everyone wants to operate. Second one is we always think that, oh, if I don't operate, patient is going to die. Okay, so I want to operate. That will be the aim of a young, enthusiastic consultant. But the aim of your operation should be, so if you operate, so what is the chance of him going back to how he was before? That should be your aim. So this patient was independent or whatever, walking at home, taken care by the carers. He was eating fine, opening his bowels. So your operation will, what is the chance of your operation taking him back to that situation is what we need to assess. There's no point you operating, patient is alive, but now becomes even more frail and lying in the bed for his rest of his life. Yeah. So that is the
So
assessment.
you mean the morbidity of the surgery itself?
Exactly. So that is what you need to consider when you make such decisions, especially with these complex patients. So you have a 87-year-old learning disability, 24 hours carer, housebound, now coming with a surgical problem. What is the chances of this guy when you operate going back to that? If you have a very good chance of that, then it's fine. Say if this patient has a, patient on had a recent MI, had say stroke. So you do this operation, they'll say the risk of stroke or risk of having another heart attack is high, yeah, which will likely to happen. Yeah, you will do the operation. Patient will lie in the ITU for more than 1 month. By the time he will develop ITU related neuropathy or whatever, he's never going to go back. So that's not the outcome you want.
That's why I was thinking about the best interest meeting with the next of kin, the anesthetist, and the
exactly.
consultant.
So before you go into the best,
version after no previous surgery, could be just a simple congenital band release.
Absolutely. So before you go into the best interest, yeah, you as an individual consultant, you need to process within your mind what we are going to do. Okay, so before that, so for that, what you need, of course, you told about the frailty. How frail is the patient? Second one is the functional status of the patient. Anesthetically, how good is he? What is the ASA stage of the ASA category of the patient? Then you need to have some, what is the risk of morbidity and what is the risk of mortality? So you do a NELA scoring, you do a NSQIP scoring. Before you take, so you should not, especially with these situations when no one has a power of attorney, we should not dump the responsibility to the next of kin, asking them, what do you want us to do? You should not do that. It is a responsibility of us, okay, us and the treating clinician to help them what would be the best situation in this situation. So you discuss, you go and speak to your anesthetist, you go and speak to your intensivist, sit and discuss what would be the options you want to discuss. Then you go to the patient's next of kin. Again here, because you have not given none of the next of kin has a power of attorney signed, or there's no advance directive, they will not be signing here. It is just, the meeting is for you to inform them, that's all. And to hear if he has told anything before. So you would ask them a question. So if this patient is Michael, so if Michael would have been fine, and if he has some way of communicating to you what he would have wanted in the situation, that's some question we would have asked the next of kin. Yeah, other than that, you need to tell that we discussed like this and this is what we feel. You can very well tell that we discussed, telling that this surgery will be too morbid for him, it is going to make him cripple and he may not be functionally active as he was before, so we decided not to operate on him and give best supportive care. You can tell that. Or you can tell that this is what it is, this is the risk of morbidity, this is the risk of mortality. I think we can try to do this, but if it works well and good, say if it gets complicated by any chance, I think at that point we need to sign a DNA CPR and give him a best supportive care. Yeah, so this is how you need to discuss such a scenario. Clear? And most importantly, whenever, so we had a discussion even in the Telegram group, whenever you have a learning disability team, you need to involve the learning disability nurse in the very beginning of the situation, very beginning itself. Okay, call the learning disability nurse. So they will have various way of communication with the patient and you involve them in discussion and things like that. Clear?
Yeah.
So this is a kind of a scenario which I want to discuss. Any questions from others, guys? Vishal, you had raised your hands.
No, that was at the start. Sorry.
Right. Yes, Qasim. Tell me, Qasim.
Just one thing in this particular scenario, I think when I'm making a decision, what I look for, especially in a patient who has a 24-hour carers and learning difficulties and all that, I think that the thing that also matters is what's the pathology or underlying cause that's causing this obstruction. I mean, in this patient, it's just a band.
Yes.
And it can be very quick, just dividing the band, early division, and he can go back to what's his normal status, as you said, is. But if it was like a cancer or something, then obviously, I mean, it's a long way to recover, and obviously he's not someone who can survive that path. So I think
100%.
I think in this case, based on that, I will do a quick one, and I mean, I've done before as well. Even a laparoscopic procedure can be done just if the radiologist is so confident that it's just a band, going in, just dividing them band, and it's a very quick 5-minute job actually.
Yes, so it's a very, so as I told, these are all situations where surgery is the least morbid part of the care. Yeah, the biggest problem of these patients is going into anesthesia, coming out of anesthesia, and most importantly, we still haven't sorted out the problem of not putting in the NG tube in this patient. Yeah. So this patient should have some kind of, or else if you want, the moment you intubate, he's going to aspirate. Yeah, with such a distended stomach. So probably he would need some kind of a sedation. In fact, give a sedation and try to do an endoscopic decompression also, or having someone like, so you need to have a plan for that, or there should be a senior anesthetist who comes and does a crash intubation. Yeah.
Okay.
So basically surgery is the, yes, of course, even if you want to do a quick, so doing a surgery, as you told, minimally invasive is good. Doing a 10-minute operation is good. Having a small incision, or even if it is a big, say, even you want to do a right hemicolectomy, in certain hands, it could be done as a half-an-hour procedure. So surgery is the easiest part in this patient. Yeah. But what is essential is how this patient is going to go into the anesthesia, how he's going to come out of anesthesia, how is he going to recover from this? That's the most important thing, where you need to have an emergency MDT, this, best interest meeting, etc., etc. Yeah, but as you rightly mentioned, the pathology matters a lot. Yeah. So if it is, say, if it is a 3, already say, for example, this patient had 3 laparotomies, and this is a fourth time presenting with an adhesive obstruction with the same picture, I would not do anything. I'll just leave him. Yeah. So we are all means we are pro surgery mainly because we think that it's a small problem. It could be a quick problem. You can even tell that, say, for example, I will put a diagnostic lab. If it is just a small band, I will quickly do and come and do. If it involves a resection and things, I will not do anything. We'll just come out and give a best supportive care. You can make a decision like that also. Yeah.
Thank you.
Excellent. Good. Right. Any other questions from others? No. So who wants to go next? Anyone? Any volunteers? Okay, Vishal. Okay, Vishal. So, is there Vishal?
Yeah, no.
Don't worry. So imagine you are doing a general surgery clinic, and you have a 58-year-old male patient referred by the GP with an incidentally detected lesion in the liver on an ultrasound scan. Okay. And because the patient had some non-specific abdominal discomfort. The patient is coming to you. I am your patient. You can get history from me.
Okay. Hello. Hi, good morning. My name is Vishal. I'm the surgical doctor here in the clinic today. How are you doing, sir?
I am good, doctor.
Can I check your understanding? What is the reason regarding your visit today in the clinic?
So, doctor, I had some abdominal discomfort, and I went to my GP. He did some scans, and he told I have a problem in the liver, and hence I came here.
Okay. Can I please ask, where is the abdominal discomfort, or is it pain, and how long has it been going on for?
No, it's been there in my entire tummy. I would not be, it's not very specific pain or something. It's just kind of a discomfort, but it's not giving me any troubles. And yeah.
And do you have any associated symptoms of nausea, vomiting, any changes in your bowel habits or urinary habits?
Nothing, doctor.
Okay. Any chance you've lost any weight recently?
No.
Any chance you've lost any appetite or your clothes?
No, doctor.
No. Okay. Fine. Any allergies to be aware of?
Nothing, doctor.
Any medical conditions to be aware of?
No.
Any previous surgeries or operations or procedures done in the past?
Nothing.
Okay. Do you mind if I ask you if you smoke?
Very, very occasionally, doctor.
How many cigarettes in a day? If
means maybe 3 or 4 cigarettes in a week.
Okay. And what about alcohol?
I do drink half a bottle of wine every day.
Every day. Okay. Fine. And Do you mind if I ask you what's your occupation? And
I am a retired software engineer, doctor.
okay,
I'm not working at the moment.
fine. Okay.
Fine. So can you summarize? What do you think? What
So
is running in your mind?
so in my mind, the symptom of the patient is just abdominal discomfort. He doesn't have any constituent symptoms of weight loss or anorexia. The other positive finding which I from the history got is just having drinking half a bottle of wine every day, which he could have. I just forgot to ask how many years he's been drinking, which could have led to any liver problems. Possibly most common could be cirrhosis of liver. Uh, and because of that, he could have some abdominal discomfort, and the GP would have requested an ultrasound. And there could be multiple differential diagnosis for the cyst which was found on the ultrasound scan. Obviously, I'll go into the ultrasound scan, have a good look at the report, and if possible, the pictures as well. But
So imagine, before seeing the ultrasound scan, with this history, which is patient doesn't have much of any symptoms. So what are all the differential diagnosis which you could think about?
Common things first. So first would be simple hepatic cyst or liver cyst. Second could be hemangioma. Third could be very rare cause hepatic adenomas. And lastly, very, very rare HCC.
What else you can have in the liver?
Hydatid cysts. And
what else? What other? So if I ask you to classify the liver space occupying lesions, how do you classify? Very simple classification is benign and malignant. Okay.
Benign and malignant,
so tell me, what are the malignant lesions which you can see in the liver?
HCC, hepatocellular carcinoma. Hepatic adenoma is benign, but it
is benign. Yeah.
Yeah.
What other things can come in liver? What cancers can come in liver?
Intrahepatic cholangio.
Very good. Cholangios. What else?
And
what's the most common malignant lesion in the liver? Metastasis.
Adenomas.
Secondaries.
Secondary.
That's the most common cancer which you can have in the liver. Okay, so you can have secondaries, cholangiocarcinomas, you can have HCC. Apart from that, you can have several other rare tumors like lymphomas and stuff, right? Okay, so you have the ultrasound scan report in your hand which the patient brings in. So what do you want to see in the ultrasound scan specifically?
I want to see firstly the site of the lesion or the cyst, where it is, which segment it is, what is the size of the lesion or the cyst, whether it is the density of the cyst, hypodense or isodense or hyperdense, whether there are any residue or any sort of like cysts in.
Fine. So you saw the ultrasound scan and you see there is a 5x7 centimeter lesion in the left lobe of liver, which is solid.
With solid components in it. Okay. So that would be a bit concerning if there is a solid component to the cyst. For his symptoms, which were non-significant, and for his age as well, I would be concerned, and I would like to obviously go through the complete report and see what diagnosis they have made.
They have told space of SOL in the left lobe of liver, refer to surgeons.
Okay. I will explain to the patient that there is a cyst there, which is having a solid dense component, which I'm not sure exactly what the diagnosis is, but it does need further sort of investigations to confirm what diagnosis is. To start with, it would be I would like to go with a triple phase CT.
Would you like to do blood test at all? What if the patient has stage 3 CKD?
Yeah, I would like to do the bloods of liver function, renal function test, and the FPC as well to know his baseline hemoglobin as well. That will help me to know if the liver functions are raised. There could be an element of cirrhosis because of his drinking habits as well.
So if you look at the blood test, okay, what specific blood test would tell you that patient has cirrhosis?
So
what is the best marker from your blood test which can tell you that patient has cirrhosis or portal hypertension?
cirrhosis of portal hypertension. I like portal hypertension if the coagulation is altered. That will help me to know. Apart from that, the liver functions, the bilirubin.
What is the important, the specific marker? Coagulation can be there in different situations. Which marker you want to look into to tell whether which will help you ascertain the degree of portal hypertension?
Platelets.
Platelets, very good. So you look into all these things. Would you like to ask any other special test given the situation apart from your routine bloods?
I can ask. I would like maybe tumor markers.
What tumor marker you want?
AFP, alpha fetoprotein, beta HCG.
Why beta HCG? Are you suspecting an ovarian met? AFP you want to ask. What else? What were your other differentials?
19.9.
Very good. What else?
And
if it is an adenocarcinoma met?
EA.
CEA. Very good. So you ask all these tumor markers. What else? What next you want?
Imaging, please.
What imaging you want?
Triple contrast CT scan.
So what is meant by a triple contrast CT scan?
So I will go for obviously the non-contrast to start with, early arterial and delayed arterial phase, and portovenous phase. After
so
that.
This is 4 contrast then, isn't it? How is it triple contrast?
The first is non-contrast.
Okay, so non-contrast, early arterial, delayed arterial, and portal. So is that called the triple phase? What do you need normally?
For
so
liver,
you can tell it as means you can call it as a dual phase or a triple phase or a quadruple phase. You don't need both early and then late. So you want an early arterial phase, portal venous phase, and a plain phase. So why do you want to do this? Why specifically for this?
Because different liver cysts behave differently depending upon what phase of contrast the scan can happen. To start with the forgotten part once.
That's fine. So this is the CT scan. I'm sharing a CT scan. Can you read it for me, please?
This is the axial images of the abdomen scan, which looks like on the venous phase, wherein I can see the liver is grossly enlarged. There is a heterogeneous mass with nodularity present on the segment 4, left side of left lobe of liver. It has heterogeneous components in it. And also there are on image C, there's a cystic hypodense lesion.
So what do you think it is? So first of all, tell me, what is this phase? What is this phase CT scan?
Portovenous phase.
Okay, then what is this?
That's the heterogeneous mass on the left.
No. What is this phase of the CT scan? This phase.
That's the arterial phase wherein the kidneys have lightened up.
Why do you say it's an arterial phase?
Because I can see the.
What do you see here? What is this?
Aorta is lightened.
Exactly. So aorta is lightened up. So why do you say it is a venous phase? What is lightened up here? Nothing. This is a plain CT, yeah? This is a plain CT. This is an arterial phase. And what is this phase?
That looks like venous phase.
Why venous phase?
IVC.
So basically in venous phase, you will see both artery and the vein. So you see here, you see here, you can see the portal vein, which is enhancing here. The artery has become less, and you can see the IVC here. You can see the IVC here. So this is the portal venous phase, and this is a delayed phase. So why do you say it's a delayed phase? What is the difference between this image and this image?
Because there is still contrast in the IVC, but it's not completely washed out.
No, there is no contrast in the IVC. Where is the IVC contrast? Nothing is there. So if I had just given this image to you, okay, will you call it as plain CT or something else? Why is it called delayed? What is the difference between these two images? So what do you see in delayed phase? So delayed phase, you see the kidneys. Yeah. So delayed phase is nothing but, so normally when a contrast is given, the initial 20 to 30 seconds, we take the arterial phase. 60 to 90 seconds, depending upon whatever organ we are imaging, we take the venous phase. Delayed phase is usually 7 to 10 minutes later. That's when all the contrast is gone and you will see the contrast only in the kidneys. That's why it is also called as IVP phase or intravenous pyelogram phase. You will see the kidneys, you will see the ureter and the bladder. Okay. So what is the find? So you find a mass here. So in the plane, there is a mass here. There is some mass here and some mass here. What is your diagnosis?
From the images, it looks like a heterogeneous mass, most likely hepatocellular carcinoma.
Why do you say HCC? Why? What is a characteristic of a HCC in a CT scan triple phase? What is a typical finding?
Mostly heterogeneous and lights up on all the three phases.
Yeah, so basically you will have an enhancement in early arterial phase and then washout in the venous phase. Okay, so why is that? Because the HCCs are typically supplied by the arteries. Okay, so in the arterial phase, you have an enhancement here, which is not seen here. Okay, although we call it as washout, it's basically not washout. Basically, what happens here is in arterial phase, it is enhancing because HCC is solely supplied by the artery. But in venous phase, the rest of the liver takes up the contrast also. That's why it looks like a washout, but it's not actually a washout like a neuroendocrine tumor or something. And then delayed phase, again, you will have an isodense lesion. So hyper-enhancing lesion in arterial phase, washout in the venous phase, isodense in the delayed phase is a typical of HCC. Okay, say you get a CT scan report telling that, okay, there is a heterogeneous 5x7 centimeter lesion in the left lobe of liver, suggestive of HCC. What are you going to do now?
I will complete the full staging scan for the patient and will refer him to the HPB liver MTD meeting.
And do you think you need a biopsy to confirm? This is just a CT scan, isn't it? Do you need a biopsy?
HCC ideally do not need the biopsy to confirm.
Absolutely. So HCC, you can just, most of the liver SOLs you can diagnose by CT scan. Only when they are indeterminate lesions, we need a biopsy to manage. Yeah. So of course you do a CT scan and then you do a CT chest, abdomen, pelvis, and you refer to the HPB MDT. What do you think HPB MDT would advise? So what are all the treatment options?
According to the size of the lesion, the location of the lesion, depending on how many segments or sectoral sectors it is involving. If it is only left-sided hepatic lesion, then it can be amenable to a left hepatectomy surgery option. And it will also depend upon future liver volume.
So my question was, what are all the treatment options? So one is resection.
Surgical, yeah.
Resection. What else?
Others are angioembolization or embolization, and chemotherapy.
So what are all the curative options for HCC? One is resection, other one is transplant. Yeah. So one is resection, other one is a transplant. And what determines whether you need to transplant or you want to do a resection? What is the determining factor?
The liver remnant volume.
No. Basically, whether it's a cirrhotic liver or not. If it's a cirrhotic liver with HCC, transplant comes up. If it is a non-cirrhotic liver with HCC, resection comes first. Of course, there are several other options starting from ablation, chemoembolization, radiotherapy, systemic chemotherapy, etc., which you don't need to know. Okay, good. Right. So how did you feel, Vishal? So you did well, actually, although I tried to help. Again, this is a very, very simple scenario, which I just want you to speak, So the most important thing when you start preparing for this exam is everything comes in your mind. But when you want to put it out, it won't come as words.
Yeah, it doesn't come out.
Again, as I told, time factor. So this scenario would be a 10-minute scenario in the exam, although I have asked you for half an hour now. Okay. So it needs to come, and at the same time, every word you deliver out should be productive. There should not be going. So, for example, you told what are the treatment options, you told FLR, left hepatectomy, and this. No, surgery, transplant, this. Yeah, something which will come by practice, but you did well. Again, imaging, I'm not putting so much of imaging here because it is a common forum where I cannot share several images which needs to be shared within a closed group. But again, you need to know in and out of everything. CT. So of course you will be learning a lot as we go through the course and stuff, but I'm just letting you know and priming you that you need to know all these things. Right. Good. Let me move on to next scenario. Who wants to take up this? Anyone? Tamir, Imam, you want to take it? No? Yes, Rami. You want to, Rami?
Yeah, I'm happy to take it, but I
Don't
might
worry.
get bleeped. I'm very sorry about that. I'm on call tonight.
That's fine. That's fine. Okay, Rami, you are on call tonight. Okay.
Yes.
And you have a patient who has been brought in, who is a 44-year-old male patient. Okay, who's been called me, who has been taken in to the hospital following a road traffic accident. Okay, and the patient has suffered a massive head injury. Okay, so this patient comes to A&E. Okay, so what you will do? So you have got a trauma bleep telling that a patient, a 40-year-old patient brought in following an RTA. Patient will be reaching in 10 minutes. So you have got a bleep now. You have been bleeped. So what are you going to do now?
So given that the estimated time of arrival is 10 minutes, I have time to assimilate the trauma team and make sure that everyone is available, including anesthetist, my junior colleague, and orthopedics, and the A&E team. As soon as the patient arrives, we will I will assess the patient according to the ATLS protocol.
Before you assess the ATLS protocol, as soon as the patient arrives, what do you want to do?
I would like to gather more information about the accident, the exact timing, the location, and whether the patient, the vital signs of the patient from the ambulance service.
Exactly. So you need to get the paramedic information on that.
Yes.
So say I am the paramedic crew. I am telling that this guy was found on the road. He had a massive head injury. He has an open scalp. Okay, and his GCS was 3/15. So we have intubated. Pupils are not reacting. But his pulse rates were fine, so he was given 2 units of blood. We have given 2 wide bore cannulas are there in place, and he's here now.
Yes.
So what do you want to do now? He's already intubated.
So he's already intubated. So is he arrived in the hospital now?
Yes.
So now I will have to assess according to the ATLS protocol, respecting the ABCDE sequence.
Mm-hmm.
So now he's intubated, so his airway is intact. I will examine his chest, looking for any chest wall deformity, any reduced chest expansion, any paradoxical movement, any open wounds, bruising of the chest, and I will
bilateral air entry is fine.
Okay, so breathing is clear, and I will check his oxygen saturations and
it's
his
98% with 40% FiO2.
Okay, and respiratory rates.
Respiratory rate is the patient is on SIMV mode and he is on 20 respiratory rate.
I'll move on to his to assess circulation, ensuring 2 wide bore cannulas are inserted, and I'll look for any visible bleeding. I will check for his peripheral pulses.
Everything is fine.
Yeah, and I will ensure that the patient's resuscitation is ongoing.
Patient is hemodynamically stable.
Okay, then I will move on to examine his GTS, so he's intubated. So I will just document his GTS. And then I will fully expose the patient and start an examination of his abdomen, given the modality of injury. So I'll look for any bruising, any open wounds again.
All normal.
All normal. I will examine the pelvis and the lower limbs.
All normal.
Okay, and then we'll ensure that bloods have been sent, including full blood counts, urine electrolytes, group and save, and serum lactate, and ensure that the patient is catheterized. And I'll request a traumagram, which is one of the adjuncts of ATLS. So CT traumagram, including head, C-spine, chest and abdomen and pelvis.
Fine. So you do a CT scan and it shows a massive traumatic brain injury with significant midline shift, with coning of the cerebellum, yeah, and rest of the thorax, abdomen, pelvis, everything is fine, with features of diffuse axonal injury.
Right. So here I would have an urgent discussion with the neurosurgeon's colleague to get advice as to whether this patient can be transferred to the nearest center where neurosurgery is available. I'll also ask the question of whether tranexamic acid would be beneficial as per the CRASH-3 trial.
So would you not give tranexamic acid based on the CRASH-2 trial here? Why are you thinking about CRASH-3? Any trauma patient, would you not give a tranexamic acid? Although I didn't intend to ask you the question on trauma, but you yourself trapped yourself, gave me the clue that I need to ask you about this. So you told that CRASH-3. Tell me, what is CRASH-3 trial?
So CRASH-3 trial, if I remember correctly now, it looked at the benefit of giving tranexamic acid within 3 hours in patients with severe head injury. It's found that it significantly reduced the mortality and morbidity.
What is CRASH-2?
CRASH-2 is tranexamic acid in patients following trauma has showed significant reduction in the morbidity and mortality and the need for blood transfusion.
Okay, so would you like to give in this patient based on CRASH-2?
Yes, yeah.
Okay, so you have given the CRASH-2, you are speaking to the neurosurgeons, regional neurosurgeons, and they are telling you that this patient has a devastating head injury which cannot be salvageable.
Yeah.
We are not accepting the patient. We can't do anything to this patient.
So I will have to document this discussion very carefully. And in this case, given that it's not salvageable, this patient is obviously very unwell. I will have to discuss this with his next of kin. And discuss with the ITU registrar, ITU colleagues, to see whether this patient would be fit for continuation of care in ITU.
What are you going to do by continuing his care?
Sorry, I trapped myself. I'm not sure in this case.
That's okay. No, that's fine. You try.
If neurosurgeons are not keen on doing any intervention,
no, they are telling that this patient has diffuse axonal injury, unsalvageable. Yeah, we cannot do anything.
Yeah.
And we are not accepting. And he has cut the call. The registrar was so busy on the other side, he has cut the call. What would be your thought process here? What are you going to do now?
So first thing, I will speak to the next of kin, inform them about the current situation, and preferably ask them to come to the hospital if possible.
Okay, so you are explaining the next of kin, telling that it is unsalvageable.
Yes.
So I am the next of kin. I'm asking, okay, so what next, doctor? What are you going to do?
So I would like to ask and look at his notes and see whether he has any advance directive on his GP notes.
Do you think a 56-year-old patient would have an advance directive?
Unlikely, yeah. Just remember the age, yes.
Okay.
Then in this case, I'm thinking of the palliative pathway in this case. The patient should be kept as comfortable as possible.
So what is the palliative pathway in this patient? So what are you going to do? As comfortable means?
So this patient will be admitted most likely on a surgical ward.
No, this patient is intubated. How can he be kept
Sorry,
in
on
these
us.
beds alone?
Yes, yeah. So we're going to have to involve the palliative team, including the pain management.
That's fine. That's the last of the thing. But patient is intubated. He cannot go anywhere apart from ITU. Yeah. So what are you going to do?
Sorry, I'm not sure. I'm stuck.
Okay,
here.
that's fine. So who else wants to continue from here? Okay. Anyone new? Okay, Abdullah Mustafa, tell me. Abdullah? Can you unmute yourself, Abdullah? I can't hear anything. Okay, I can't hear anything from him. Okay, Qasim, tell me.
So I will involve the organ donation nurse after the patient has been transferred to the ITU so that she can check in the register there is no wishes are,
So imagine you are facing that situation tonight. How are you going to reach this organ donation nurse?
I think there is a contact number there in the ITU that you can call, and usually they come and they actually check first the register, and after they have ruled out that there is no contraindication or wishes expressed against it, then the family is contacted, or the next of kin and their family is contacted about this, and the organ, and then the next step comes about then the confirming the brainstem death.
Okay, so but that one you don't need to. So imagine you call the next of kin, yeah, or the GP notes. Okay, so what is the present organ donation law? What system we have in UK? Say for example, I am a resident of UK. Okay, I have not told anything, so I have a brain death today. Will they take my organ or not?
I'm not 100% sure about, but I think every person is can have an organ donation actually on.
No, that is a can have. So the law in the UK is an opt-out system now. Okay, we have moved from opt-in to opt-out. Maybe I think it was in 2020, if I'm not wrong, or 2019 even. So what happened was, instead of you registering as an organ donor, okay, now we have come as an opt-out system. And if you don't want to donate, you need to tell I don't want to donate. If you don't tell anything, your organs once you die belongs to the state. Okay, the family, yes, the family will be told. So family, but if the family declines for organ donation, yeah, for example, you have this 56-year-old guy, you think that he is a very fit and well guy, and he has not told that he wants to not donate. So you decide that he is an organ donor, and this is what you need to communicate to the patient's relatives, telling that he is an organ, so he has not opted out. So we are planning to take his organs through different path, and you'll be explaining all these things, yeah, in a polite way. You cannot be telling that, oh, he is dead, I'm going to take out the organs. You need to ask the patient, the next of kin. What you will ask is, you won't be asking them whether you are okay with this decision or not. What you will be asking them is, has he expressed any wish against organ donation? Okay, if the family members tells that no, he is very, very religious, in our religion we do this and that, and if he was alive he wouldn't have accepted this, and if you strongly believe that that is a valuable reason, then you go with the patient's next of kin, telling that, oh, we are not going to retrieve the organs. Okay, so that you need to get. So if the patient has opted out already, you don't need to call them. Okay, so who is this nurse which you are telling? What's his or her name?
That's the organ donation liaise nurse, actually, who liaise with the organ retrieval team.
Who is SNOD? SNOD, SNOD. These people are called a specialist nurse for organ donation. SNOD, SNOD. Okay, so many candidates used to tell that they'll speak to the transplant coordinator. So transplant coordinator's job is not this. and the transplant coordinators will be there only in units which does transplants. Okay, so whom you need to call is, if at all, if you have a potential donor, you call the NHS-BT, NHS blood and transplant. Okay, you call them and tell that you have a potential patient like this. You tell all the details, and the NHS-BT will allocate a SNOD. Okay, who comes in here and assess whether the patient is okay or not, what else, and he or she will coordinate the entire process. Okay, imagine this patient is ready for organ donation. Okay, the SNOD is coming in, and SNOD feels that he is a potential organ donor. What would be the next step?
The next step is to confirm the brainstem death, and that's basically done by the two registered doctors. One has to be a consultant, and they do a series of the brainstem function tests, 2 of them, and usually after the first test, if there is no functioning, then the time of death is declared after when the first test was completed.
So what are the prerequisites before they do a brainstem testing?
The prerequisites are to rule out all the conditions that can cause a coma-like state, like a hypothermia, any opioids or sedatives, any electrolyte abnormalities, any other condition like uremia or sepsis, for example, or so all these kind and conditions needs to be ruled out first.
Okay, fine. You did this, and what are the brainstem tests? Are you aware of what are the two groups of tests?
Yeah. So it starts with a supraorbital. The supraorbital pressure is no response, then corneal stimulation, and then light reflex, then vestibulo-ocular test, then gag reflex.
Fine. So you do this test for him, and patient has gag reflex.
So it means, I mean, it means that he still has some brainstem functions.
So what are you going to do now?
I mean, the patient has to be declared death when there are no brainstem function. So in that case, I mean, he hasn't passed that phase, so he will be declared that he's not brainstem death at the moment.
So what next?
We have to wait.
How long? Okay, so you wait for one more day, continuing the same care. Next day, you are repeating the test, and again, his gag reflex is there.
I'm not sure, but I think this is the time when there is an MDT decision and when to withdraw the sport, actually. So there has to be an MDT decision with the intensivist and next of kin that it's a condition that's not going to improve, though he's still not having a complete brainstem death. But
so my question is, can he donate organs or not?
I mean, there is some delay, but I mean, he's still, there was no wishes against the donation, so he can donate.
How can you take out organs without declaring death?
No, what I was trying to say was, I think at some stage we have to stop the sport that he is on, so like ventilatory sport, if there's no chance that he's going to recover.
So you stop the supports in the ITU, he dies. How are we going to take out the organs?
Sorry, I'm not sure about this situation.
Okay. No, but whatever you have told so far is right. Anyone who wants to continue from here? Anyone? Chris, you want to continue from here, Chris?
Yeah, can I have a go?
Mm-hmm.
So it might be suitable for as a DCD donor. So I'd liaise with the SNODs. For that to happen, the transplant team obviously needs to be alerted and brought to the hospital.
What is a DCD donation?
So that's death. So it's donation after circulatory death.
Mm-hmm. So how is it done? Who are the patients who are for DCD donation?
So those that don't meet the brainstem death criteria, such as this patient.
Anyone else?
With those that don't get to the point of being tested because they have a cardiac arrest or deteriorate from another cause. So those are the sort of, I think those are considered the controlled donors.
So how is DCD donation done?
So support is withdrawn.
Where are these supports withdrawn?
It's usually done on ITU, so the transplant team isn't present in. They may be ready in theatres, but they're not physically there in ITU. Troops withdrawn, and then essentially we wait and see if the patient dies. Sometimes that process can take a number of hours, in which case the ischemia time would preclude any donation. But if they die fairly rapidly, I think they then have to be declared dead after a period of 5 minutes, and then they could be rushed to theatre and organs could be retrieved.
Very good. So yeah, so there are two types of organ donation. One is DBD and DCD. DBD is very straightforward, donation after brain death. Any patient who comes in, you do the brainstem testing, you declare them dead, brain dead. Okay, they are dead at some point, but every other system is functioning fine. You maintain this dead person, and transplant team, the retrieval team will come. Patient will be taken to theater under ventilatory support. You do the retrieval. That is a DBD donation. Donation after cardiac death is where any patient in the ITU whom we think that withdrawing the support will not give him a life. All these patients could be considered as a potential DCD donor. It is not just head injury alone. For example, patient who had a massive stroke, having a major intracranial bleed, okay, and you think that he is not going to recover. Okay, he is not having spontaneous breath. Again, for those patients whom you think that, okay, he has no other option apart from withdrawing the life support, they could be a candidate. Patients who have respiratory failure, who are dependent on ventilators, okay, withdrawing the support, he is not going to live. Again, those patients could be considered as a donation after cardiac death. So any patient where an intensivist and a treating team think that withdrawing the support will not keep the patient alive could be considered as donation after cardiac death. So DCD in the UK, we always do a controlled DCD. In countries like Spain and other countries, we could do something called uncontrolled DCD, where even when the patient dies on the road, for example, they will be cannulated on the road and they will be brought in and still we take out the organs. But in the UK, we do something called as controlled DCD. So whenever you have a patient like this, where the brainstem testing fails and you decided that he is futile without a supportive management, we still call the SNOD who comes speak to the team. The retrieval team will come. They'll be ready in the theaters. Everything will be ready. This patient is generally taken to the pre-anesthetic room rather than in the ITU. Patient will be in the pre-anesthetic room where they will extubate, stop the inotropic supports, and wait to see if the heart stops. The moment the heart stops, as you rightly mentioned, if patients like this whom we discussed, they die quickly, but patients with respiratory failure and all, they'll take a long time. Yeah. So for retrieving liver and pancreas, heart, we keep 1 hour as a time. From the time of withdrawal until 1 hour, we wait. And if the patient dies within 1 hour, we take out these organs. If it's anything more than 1 hour, all these organs won't be withdrawn. We will just retrieve kidneys. We wait until 3 hours for the patient to die. If the patient doesn't die until 3 hours, we cancel the retrieval. We come out. This patient will be taken to some supportive room, wait for the patient to die. Whenever patient dies, patient will die. And then the patient will be sent to the mortuary. Okay, this is called controlled donation after cardiac death. Okay, so this is how it is done. Again, SNOT comes in and so for whatever question you told was right. Majority of the candidate, although this happens in every trust almost now and then, many of the general surgeons and registrars, they don't know. Yeah, and it's a very, very common scenario. In every alternate exam, you will have a question on organ donation. What is the Organ Donation Act? What is the brainstem testing? What is DBD? What is DCD? How will you approach the situation and things like that? Okay. Another common question is, say you have a brain dead donor, but the retrieval team is coming, takes like 3 or 4 days to come because they're all so busy. How are you going to manage this brain dead person in the ITU? Again, that's a very common question in the exam. Yeah. Right. Any questions so far? Good. Yes, Qasim, unmute yourself. Yeah.
Yeah, the same scenario you just mentioned. So what's the answer?
Which scenario?
You just mentioned. The retrieval team is late, is not
Yeah.
coming in 3-4.
No, so it's just the same. You know, there are certain criteria which we need to maintain in these brain dead donors. Like we need to maintain the map of the mean arterial pressure should be like this, urine output should be like this. We need to start angiopressin at some point. Patient will go for what is it called? The blood sugars will be going up. We need to control the blood sugars. Blood gas should be kept under control. Things like that. It's just as maintaining any other normal patient's hemodynamics, okay? An antibiotic should be there and things like that, okay? Which we will discuss, okay? Right, so hope the last 2 days you did have some essence of what these scenarios would be, okay? So we will be discussing a lot as we go through the course, okay? And as I told, I think most of you here are our course participants. So we are starting our course this Sunday. So please make sure you go through the schedule and keep yourself available on the course days. Okay. Use the Telegram group, and the assessments for the course would be every Viva you tell or every response you will tell, we will assess you. And at the end of the first month, you will have a report of how was your performance. At the end of the second month, you will see how was your performance. All the sessions will be recorded. You will be having it to see within 24 hours in your app for you to review. We have all the essential materials to review. Yeah, and that's how it is. And at the end, we will have the mock exam. And any one of you here, if at all, if you're planning to take exams later, and if you want to access the library alone for some reason, whether you can't join the course, because you cannot commit yourself for 3 months, we have various libraries and stuff which is designed for the exams, and you can use it. Okay, good. So all the very best, and I hope you found these 2 days very useful. I will see you during the course. Bye.
Thank you.